Thank you so much, Filippo. Thank you for accepting this invitation. We are honored. Thank you so much, Filippo, and let's get started with your conference.
Thank you, and it's my honor and privilege to deliver this online webinar. We slightly changed an agreement with one from diastolic dysfunction in sepsis to a broader discussion on diastolic dysfunction in the critically ill patient. Why the slide is not moving? Okay, yeah, perfect. So in the summary, what we will go through what is the definition and diagnosis of LV diastolic dysfunction, its impact a bit in the perioperative setting, and then we will focus mainly on the impact in the ICU, which is I'm sure what you are more interested, and some suggestion on how to deal and how to optimize the patient with LV diastolic dysfunction. So for ages, we have been focusing on a number, LV ejection fraction, which roughly tell us information about systole, but it's not only about squeezing blood through the heart into the systemic circulation, but it's also about relaxation, because a ventricle that can't feel well, of course, can't eject very well, so the stroke volume will go down. We now know that diastole is an ATP-dependent process, is an energy-dependent process. And indeed, during ischemia, the patient has got impairment of diastolic function even earlier than the systolic impairment. So that's important. And when we talk about diastology and the study of diastolic function, I tend to ask my trainees what is their definition of diastolic function, and I tell you that most of them really struggle with that because it's easy to define a systolic function by saying a magic number of ejection fraction. Is a bit more complex of diastolic function. And I would say that a normal diastolic function is in condition when we have a filling of the left ventricle that happens despite low left atrial pressure and therefore a low left atrial to LV gradient. Therefore, we will have low LV and diastolic pressure. What happened in diastolic dysfunction is that this is taken from the most recent guidelines, this definition. We have an impaired relaxation and increased stiffness of the LV, which finally ends up in LV and diastolic pressure, which becomes higher. I want to do a premise on diastolic dysfunction. Please do not confound with diastolic failure, because diastolic dysfunction is an echocardiographic finding which you make after you are trained in echocardiography and you are able to interpret several parameters. While diastolic heart failure is a different thing, is a scenario of heart failure with symptoms of heart failure in presence of a normal LV ejection fraction and normal mitral valve apparatus. So we will move during this talk from the physiology of diastolic dysfunction to the recommendation recently published for the assessment, and finally we will move on the more interesting part. As you can see, the baby is now smiling on understanding the clinical relevance, because I think we are all clinicians interested in what is the clinical relevance or what we do in order to do something better for our patients. So let's talk about the physiology. You are all familiar with that, and you know that during this phase, before the ejection, the left ventricle pressure rises up, and when it becomes higher than the pressure into the aorta, then the aortic valve opens. There is the ejection of blood through the aortic valve, which goes in the systemic circulation. And when the pressure in the left ventricle drops below the aorta, then the aortic valve closes. And now we start diastole. With a relaxation, you can see this line, relaxation of the ventricle, and the steeper is this relaxation, the better is the diastolic function, and the chamber are less stiff. So during this phase, which we know is the isovolumetric relaxation time, the heart relaxes. And finally, when the pressure in the left ventricle drops below the left atrium, then we have an opening of the mitral valve and the early filling starts. And this is, in normal condition, dominant as compared to the atrial filling, which happens when the atrium contracts. But before that, you can see that the filling of the left ventricle brings the pressure higher than in the left atrium, and therefore the mitral valve tends to close. And then the atrial contraction increases the pressure in the left atrium, and the mitral valve opens, and there is the second part of the filling in patient with sinus rhythm. As you can see, this is the ECG plot, and which is plotted here, and the P wave in correspondence of the atrial filling. So in a normal diastolic function patient, we have a dominant early filling in the transmitral blood flow. I'm sure you are all familiar with that. This is a transesophageal imaging. Now let's look at the left part of the figure here. This is taken from the new recommendation of the assessment of the LV diastolic function, the European and American joint recommendation. And you see they look pretty much similar, but this is in normal end diastolic pressure condition, and this is high end diastolic pressure condition. Because what is different is the scale here. This ventricle is normal, and the pressure drops at the end of systole, and when diastole begins, roughly to 5 millimeters of mercury, while in the ventricle that has got high end diastolic pressure, the pressure drops to 10, is unable to relax well, and is a bit stiffer, and therefore pressure doesn't drop to a normal level, so to 5. And if you look this area that I look here with the arrow, it's smaller than this area. So now when we move in this part of the figure on the right-hand side, we see what means normal ejection, relaxation, and then we move in a condition where the ventricle becomes stiffer, the curve is less steep in the relaxation, and therefore the early filling decreases. You see how smaller is this than this E wave, and the atrial filling becomes bigger. You see that this part, I hope you can follow nicely the arrow, here is bigger than here. Now the next step is what is an adaptation from our body, and basically what it is about an increase in LA pressure, which is higher now, and this restores the gradient between the left atrium and the left ventricle, and therefore we have a E wave which is bigger than the A wave, but this happens at the expense of high LA pressure, and we call it pseudo-normalization because it looks normal but is not normal. I let you watch this video on the progression of diastolic dysfunction. I think this video is very nice. It shows how the EA ratio changes according to the LV-LA pressure when we move to abnormal relaxation, and then finally to pseudo-normal, and then to the third degree, which is restrictive. Now I let you watch another time for this video. And now we are moving to the restrictive, when the pressure in the LV are very high, and even a tiny amount of blood brings up the pressure consistently. Indeed, if you see here, the E wave becomes even bigger than the A wave because the atrial contraction can't fill the ventricle, because the ventricle has got so high end diastolic pressure that it can be filled even with atrial contraction, active atrial contraction. Now, it would be nice if it's that easy, but it's not that easy. And for instance, age, heart rate, presence of heart valve disease, all these things can influence the diastolic function and the evaluation. This, for instance, is an evaluation that you can see in a patient according to age. And you see how the EA ratio becomes half between young adolescent and going to people older than 60. Same with the E prime value that changes and diminishes a lot. So age is one concern, but even the same patient put under stress, so going to do exercise, there are lots of changes in most of the variables. Only the EE prime ratio looks pretty much the same if the patient has got normal heart function, but the other parameters change significantly. And this is because the heart rate during exercise increases. And you know that tachycardia allows for shorter passive filling, therefore there is a reduced E wave, while bradycardia allows longer diastolic time, longer passive filling, increased E wave. And also, with regards to heart rate, you can see a clot in the left atrial appendage here in 3D, here in a 2D zoom image in transesophageal. When you have atrial fibrillation, the EA ratio is not anymore there because you don't have an atrial contraction, so you can't evaluate EA. And finally, moving to heart valve disease, it's difficult to evaluate transmitral blood flow in the presence of such mitral valve stenosis. This is a 3D view from the left ventricle. It's difficult to evaluate the transmitral blood flow in condition of mitral regurgitation, aortic regurgitation, etc. So it's not that easy, and someone may get confused, lost, or whatever. But the new recommendation provides some help. But let's see before the new recommendation where we were up to a few months ago, a year ago roughly, we were with the 2009 guidelines where this was a kind of practical approach to grade diastolic dysfunction, and despite this practical approach, there are lots of parameters in here to evaluate the degree of diastolic dysfunction, and the problem was that lots of patients still remain with indeterminate diastolic function. This is a very important point, that we were not able to define what was the normal the diastolic function normal, or what was the degree of dysfunction in several patients. The new guidelines published in July 2016, if I'm not wrong, are very interesting in this regard, because they help us by recommending, in most cases, only 4 variables for the diagnosis of LV diastolic dysfunction. So the 4 variables are the following one, and you see the first 2 are TDI-derived variables, so tissue Doppler imaging. We will talk a bit about these 2 variables. And then we have the left atrial volume index and the tricuspid regurgitation peak velocity. When we look at what are the abnormal values to diagnose the LV diastolic dysfunction, we see that E prime myocardial velocity at annular level below 7 centimeters per second in septal and below 10 at lateral level is 1 point. Similar for the E prime ratio, which on average more than 14 or more than 15 if we use E prime from septal level, and more than 13 if we use E prime from lateral level. And then LA volume index more than 34 mL per meter square of BSA, body surface area, or a tricuspid regurgitation peak velocity of 2.8 or more meters per second, which translate in a gradient between the right atrium and the right ventricle of roughly 32 millimeters of mercury. So what happened in the grading of diastolic dysfunction is that the relaxation of the LV is impaired in all the cases of diastolic dysfunction, while the left atrial pressure starts to be elevated only on grade 2. All the other 4 parameters that are used for the evaluation of diastolic dysfunction are listed here, but of course they may not always match. So for doing diastolic dysfunction diagnosis in patients with normal ejection fraction, we use these 4 parameters, and we use this approach. If less than 50% are positive, we have normal diastolic function. If more than 50% are positive, we have diastolic dysfunction. While if 50% are positive, we stay in the indeterminate diastolic function condition. One very big change, and please keep this in mind, is that with the new guidelines, the authors state that if a patient has got abnormal LV ejection fraction, by definition, there is diastolic dysfunction. So all the patients with, let's say, 45% ejection fraction will have diagnosed diastolic dysfunction, and then we have to move to grading. With regards with the grading, it's pretty much simple. We use the same variables, and then we use EA ratio and E wave peak velocity. This is taken from a paper by the group of Sam Orley and Stephen Wang, recently published in Annals of Intensive Care, but basically is easier than it was before. I'm not going through that because it requires training and everybody should study it and so on. I'm going to show the impact of these new guidelines on the diagnosis of diastolic dysfunction and on the grading in the general population. This paper by a Portuguese group is very interesting. It's published in the European Heart Journal. And what the authors did, it is a retrospective study, so with some limitation for its design, but they studied the prevalence of LV diastolic dysfunction in 1,000 of people with 45 years or older than that. And it is striking, really striking to find that with the new guidelines, we have 1% of patients, 1 to 2% of patients with diastolic dysfunction, while with the previous guidelines, the same patient, we had 38.1% patient with diastolic dysfunction. And as you expect, they found really poor concordance between guidelines. However, even more interestingly, the paper I mentioned before by the group of Tony McLean, Sam Orley, and Stephen Wang compared in patients with sepsis and septic shock the application of 2016 guidelines with the one of 2009. And what they found, they did this evaluation on day 1 and on day 3. So if you look at the number of patients, at the percentage of patients with indeterminate diastolic dysfunction, certainly the new guidelines are able to decrease significantly the amount of patients with indeterminate diastolic dysfunction. Which of course translate in an increase of patients with diastolic dysfunction, an increase of patients with normal diastolic function, because it's just a distribution of this 50 to 60% of patients that were indeterminate with the previous guidelines. I find this paper very interesting. It's open access. This is taken from the paper itself. You can look in PI. I just put here in table. I recommend reading this nice paper. Now, let's go back on the first chapter of the new guidelines. What they say. They say the guidelines are not necessarily applicable to children or in the perioperative setting. I would argue that they should have written about critical ill patient, which is even more complicated than the perioperative setting. Why? Because if I put again the 4 recommended variables, and we think about using the left atrial volume and the tricuspid regurgitation jet in patients undergoing mechanical ventilation, large fluid shift, inotropes and vasopressors, like our septic patient, can we really use them? For instance, PEEP and high intrathoracic pressure will cause a certain impairment of the right ventricle. The right ventricle can dilate. It can make worse the LV filling for that. In patients with large fluid shift, are we sure that the TR jet velocity is the same in condition of severe hypovolemia? Are we sure the LA volume doesn't change a bit? And also the use of vasopressor, inotropes. So basically, there is a quite significant difficulty nowadays in echocardiography because we use parameters that are derived by the outpatient clinic, where the patient, even with some difficulty in some case, let's say heart failure patient, they walk to the cardiology ambulatory and they have their own transthoracic echocardiography. And we want to compare these values with the one in a patient that is septic. that's really difficult. So the other two parameters are probably more reliable, but of course they are influenced less by loading condition. We know that the tissue Doppler imaging is less influenced by loading condition, but we don't know the action of inotropes, vasopressors, of their dose, how can modify the tissue Doppler imaging. Now, this is taken from the British Society of Echocardiography, but just to show that the behavior of E'-A' ratio is different from what happened to the EA ratio, because here we have a pseudo-normalization of the pattern, while in the case of tissue Doppler imaging, the EA ratio keeps decreasing, and the E' becomes smaller and smaller and smaller the more is affected the LV relaxation. For those of you that are not familiar with tissue Doppler imaging, what this echocardiography approach does is to evaluate with pulse wave Doppler the myocardial motion. This is a transesophageal image where we see the myocardial motion is investigated at the mitral annulus level, and is investigated with a low velocity and high amplitude signal, because the myocardial velocity is lower than the blood flow velocity and it's got higher amplitude. And what we see that during systole there is a contraction that goes from the base to the apex, while in diastole we have a movement from the apex towards the base. So in the case of transesophageal echo, it will be the opposite in transthoracic. You will have a positive E' and A' and a negative S', which is the systolic tissue Doppler imaging. And the easy stuff is that you have to remember just few numbers, that a normal diastolic function happens in condition of E' more than A', that the average E' is roughly more than 8.5, and the E' ratio is below 8, like in the case is shown here in cardiac theater, where we have a septal E' of 10.5 and a E' ratio of 7.1. Okay. Let's move to the more interesting part probably of the talk, at least the one I like more, where we will find studies evaluating diastology and patient outcome. I think before moving to the critically ill and the perioperative period, we have to show some paper on the general population. And I find very interesting these three papers. They all come from quite important journal, New England, JAMA. So the first paper by Gandhi show how after 50% of patients presenting in emergency department with pulmonary edema, they have got preserved LV ejection fraction and a normal mitral valve. So the reason for pulmonary edema is a precipitation of diastolic function. And similarly, 50% of acute heart failure hospitalization have normal ejection fraction. And interestingly, in the paper from Redfield, LV diastolic dysfunction in the general population was 4 to 5 times higher than LV systolic dysfunction. And more than half of the patients with heart failure within this large population that was studied had preserved ejection fraction. So now let's look at the perioperative period. In the perioperative period, I'm sure no one will be surprised that LV diastolic dysfunction is predictive of difficult weaning from cardiopulmonary bypass and inotrope requirement in cardiac surgery. But I can tell you more: longer length of stay in the ICU, in hospital, higher mortality, etc., etc. Similarly, in vascular surgery, open vascular surgery, is predictive, diastolic dysfunction is predictive of heart failure, prolonged hospital stay, short and long-term cardiovascular events. So it seems to matter. Now the question is if it matters for the patient with some degree of cardiac comorbidities undergoing non-cardiac, non-vascular surgery. Unfortunately, we have just few studies because it's difficult to do echocardiography in the OR. Maybe you got less anesthesiologists trained with echocardiography, less interested, maybe not a machine readily available in the operating room, etc. But I find interesting this paper by Cabrera, Schulmeier, and Ariaza. They found that in patients undergoing abdominal, orthopedic, and urological surgery, they stratified the patient according to the EE prime ratio, which is a surrogate of left atrial pressure. And this group has normal EE prime. This group is in the gray zone, and this group is really in a bad zone with EE prime. And the group with higher EE prime ratio has got an increase of pulmonary edema at 24 and 48 hours, has got higher incidence of arrhythmias, higher risk of death, higher ICU days, and higher length of stay in hospital. And there are also some changes which are seen also in the people in the gray, in the patient in the gray area, like increase in pulmonary edema in the second day, increased arrhythmias, and increased length of stay both in hospital and in the ICU. So my answer to the question, if the diastolic function in the perioperative setting matters, is yes. Of course, the more challenging is the surgery and the more sick is the patient, the more you should take care of it. Let's move on the part which will match more your interest, which is the one on critically ill patient. And I will talk mainly about sepsis and the weaning of, from the ventilator. So sepsis and LV function or dysfunction, as you like. We now know that sepsis is not only about vasoplegia, and that despite high cardiac output in most of the patients, we have myocardial dysfunction, as you can see by longitudinal strain echocardiography, and there are quite decent number of papers coming out on this topic. With regard to septic cardiomyopathy, there are lots of review. I'm not going to talk too much about what is the mitochondrial dysfunction, the cytokines, the histones, and whatever. But I want to show this interesting animal study by the group of Alexander Mebasa, where they showed that in rabbits treated with endotoxin, the pressure volume analysis showed not only some impairment of systolic function, but that all the indexes of diastolic function were worse. So they showed 100% worsening in diastolic function in rabbits treated with endotoxin and therefore brought to septic shock. Now let's look at the outcome. This is the meta-analysis that prompted my studies, and I'm really grateful to Stephen for bringing more light on this topic. And what the group of Stephen Wang did is to look for ventricular dysfunction or dilatation, and to look whether there was an association with mortality in severe sepsis and septic shock. And they included 11 studies with over 700 patients for LV function, while data on RV function were a bit lower, half of the studies, 400 patients roughly. What they found no association between LV systolic function and mortality, and similarly for the RV systolic function. But I find very interesting that the p-value is low, and the forest plot almost crosses the midline because it favors survival in patients with worse LV function. So it seems that worse LV function seems better for patients. But probably this is because the problem is in how we evaluate systolic function, because LV ejection fraction, for its geometrical assumption, for its load dependency, is not probably the best parameters. However, until we will evaluate LV systolic dysfunction with ejection fraction, we can say that probably is not associated with mortality. And in this regard, a paper from Joseph Paonessa compared patients with hyperdynamic LV ejection fraction, so with those with more than 70% ejection fraction, versus those with normal ejection fraction, which was defined as 55 to 70%. And this was done not in septic, but generally in the intensive care unit. There were both sepsis and non-sepsis patients. The prevalence was roughly 8 to 9%, so 1 in 11 patients got that. And the important finding of the study is that hyperdynamic LV ejection fraction is significantly associated with mortality at 28 days, that it seems the stronger predictor in the multivariable logistic regression analysis, you see, with an odds ratio of 1.4 almost. So this is very interesting. But ejection fraction is probably not the best way to measure the systolic dysfunction in patients with sepsis, because it is load dependent, it has geometrical assumption, and it doesn't account for regional wall motion abnormalities. We are very interested in speckle tracking echocardiography, and we are conducting a meta-analysis on that. And this will be hopefully published soon, but it's still under review, and I can't show the findings, but these are interesting. And we can do a seminar maybe later on when this will be out. Now, let's go on the paper, which is my most important, or at least my most quoted paper, is this meta-analysis on diastolic dysfunction and the outcome of septic patients, where we were able to include 7 studies with over 600 patients evaluated for LV diastolic function by tissue Doppler imaging, and 5 of these studies provided also values of LV ejection fraction and were evaluated as a secondary outcome for systolic function. So this is our main finding in the primary analysis. So LV diastolic dysfunction is significantly associated with mortality. You can see the forest plot that crosses completely the midline, and it's associated with higher mortality in severe sepsis and septic shock. On the other side, when we look at the systolic dysfunction, again, 5 studies, 580 patients, we found, as Stephen Wang found, no association between mortality and systolic dysfunction. Coming back on this study, on the main finding of the study, we did look for parameters that are associated or not with mortality in patients with severe sepsis and septic shock. So what we did in the recently published paper meta-analysis in the BJA, we investigated the association of tissue Doppler imaging variables, so E prime values and EE prime values, with mortality in severe sepsis and septic shock. And with regards of E prime, we found that better values, so higher values of E prime, were associated with survival. And as expected, lower E prime ratio, so lower left atrial pressure, lower end diastolic pressure of the left ventricle, are correlated with higher survival again. So if the question is about the association between the LV diastolic dysfunction and the mortality of this septic patient, I would answer that yes, there is a strong association. However, please bear in mind that these meta-analyses are not corrected for confounding variables. It is possible that the patient with diastolic dysfunction are those with a higher degree of comorbidities, and therefore they show higher mortality. That's why we need more research to understand the correlations rather than only association of echocardiography parameters and mortality in the ICU. However, if you still believe that there is an explanation why diastolic dysfunction may bring higher mortality, I would agree that the patient with diastolic dysfunction need adequate filling and preload to maintain sinus rhythm and to avoid tachycardia. And if we believe that, and we look at what happened in sepsis, it happens that we have a serial disruption at this level with relative hypovolemia, tachycardia, and a lot of arrhythmias with patients developing atrial fibrillation in up to 23%, according to this systematic review. So 1 in 4, 1 in 5 patients with sepsis tend to develop atrial fibrillation. Now, what we can do about? We will come back on what we can do generally about diastolic dysfunction. But in the case of septic patient, I think we don't have many things to do, but certainly there is a chance that beta blockade can be an interesting alternative, because beta blockade may reduce tachycardia and they've got antiarrhythmic effect. And we know, as I said in the previous slide, that sepsis is an independent predictor for new onset atrial fibrillation. We know also that beta blocker improve diastolic function in patients with diastolic heart failure, and they improve LV filling pressure and coronary flow reserve even in patients with uncomplicated hypertension. And I find very interesting the study by Andrea Morelli, which is the largest trial so far published on the use of beta blockade to control the heart rate in patients with septic shock, where the authors randomized patients according to with a control group with placebo and a group intervention group receiving esmolol to a target heart rate of 80 to 94. The group of esmolol showed improved cardiac performance, so probably the beta blockade made it more efficient, and then a reduced norepinephrine requirement, reduced fluids, reduced troponin T, lower lactate, lower higher EGFR and better gas exchange, and finally lower mortality. I was very interested at that time in this therapeutic option, and with Andrea Morelli we reviewed the Medline on that. A lot of animal studies rather than human studies, but it's interesting to note also that beta blockade may modulate immune function and metabolic function in a positive way, especially the beta-1 blocker, and they may have also some effect on coagulation, but this is should be better studied. Now, I want to show something on the importance of diastolic dysfunction in the weaning. Because when we have a transition from positive pressure ventilation to spontaneous ventilation, which is done with negative pressure, we put the LV in unfavorable condition because we cause increase in afterload, increase in preload, and a patient with diastolic dysfunction may suffer from that. And we know also that during this period, there is a chance of triggering myocardial ischemia, which in turn will worsen the systolic and diastolic function of the patient. Now, the group of Jean-Louis Teboul showed how most of the failure with are caused by pulmonary edema. Of course, the patient can fail for many other reasons, but weaning-induced pulmonary edema is one of the my apologies. Weaning-induced pulmonary edema is one of the most frequent causes, and it's more frequent when we are in a condition of preload independence, so when the patient is very well filled. And in the next slide, I show you how these 4 studies, and there are a few more on the Medline, show the impact of diastolic dysfunction in the weaning process. There are some papers that show also that failing patients have got lower ejection fraction. But there are other papers where LV ejection fraction does not differ between the failing group and the group succeeding in the spontaneous breathing trial. However, all the papers are concord that either higher E prime or lower E prime are predictive of spontaneous breathing trial failure. And in the paper by Moschetto, they found that a EE prime of 14 to 15 can predict weaning failure with a specificity of 96% and sensitivity of 75%, as well as the paper of Konomi that found an independent association of LV diastolic dysfunction with weaning failure with a quite striking odds ratio of 11. It was 11.3, I think. So, in this regard, I find very interesting this paper by the group of Xavier Monet and Jean-Louis Teboul, where they, it's probably the larger study on this regard, and they showed that in a population over 200 patients, the incidence of weaning-induced pulmonary edema was almost 60% in the failure of the spontaneous breathing trial. And interestingly, you can see, I'll move the photo away and the video away. So the left ejection fraction at baseline in patient with weaning-induced pulmonary edema and in patient without weaning-induced pulmonary edema is pretty much the same. Actually, it's a bit higher, though not significantly, in the group with weaning-induced pulmonary edema. But what is different, and is significantly different, is the EE prime ratio, where the group failing and having weaning-induced pulmonary edema have got a significantly higher EE prime ratio. Now, it is also very interesting to look for a subgroup study in this paper, where the patients that were monitored with cardiac output monitoring, it's a group of 85 patients. And what the authors found in the group with failing spontaneous breathing trial was that patients failing but without weaning-induced pulmonary edema maintained the same global end diastolic volume, while the patient with weaning-induced pulmonary edema had a significantly increase in global end diastolic volume. And a similar explanation, the amount of extravascular lung water in case with weaning-induced pulmonary edema, of course, increased significantly, 0.03 from 11 to 14, while the cases without weaning-induced pulmonary edema maintained roughly the same extravascular lung water. This prompted our letter, published in Critical Care, where we focus on these results that I mentioned, and we believe that diastolic dysfunction was a key player in this regard. The higher amount of blood that comes back to the heart when the patient has a transition from positive to negative pressure ventilation cannot be accommodated if there is diastolic heart failure and goes out in the lung and causes pulmonary edema. So I hope I managed to convince you that diastology in critically ill patient matters, is very important and should be a focus of research. But of course, I expect you to ask, what should I do then with diastolic dysfunction after I do my training in echocardiography, I'm able to diagnose diastolic dysfunction, etc. So, apologize for these emails. The bad news is that diastolic dysfunction does not have a magic bullet. We don't have a magic pharmacological bullet to rapidly improve diastolic dysfunction. There is some drugs that may improve diastolic function. We have spoken about beta blockade. There could be levosimendan, but again, it's not easy. It's not at least as easy as bringing up the blood pressure with a bolus of norepinephrine or epinephrine, etc. But what I would recommend when you approach the patient with diastolic dysfunction is to have a proactive approach A proactive approach means that assuming you have a patient with grade 1 LV diastolic dysfunction, then you should be careful on atrial fibrillation, because in this patient, the atrial wave is bigger than the E wave and accounts for a much larger proportion of LV filling than under normal condition. So let's say that you have a patient with normal systolic function that in atrial fibrillation develops low blood pressure. That's probably due to the fact that he's got significantly impaired diastolic function, and the atrial filling is quite important for this patient to maintain a good LV filling and therefore a good stroke volume and cardiac output. In the case of grade 2 diastolic dysfunction, we need even more proactive approach, because this patient relies on higher LA pressure than a patient with normal or grade 1 diastolic dysfunction in order to maintain the LV filling. And in case of hypovolemia, so if we lower this line here, we decrease the E wave. And we know that hypovolemia is also a trigger for atrial fibrillation. So assuming this patient develops hypovolemia and atrial fibrillation, this patient is in trouble. On the other side, I'm not recommending you to overfill this patient, because this patient with high LA pressure may develop easily pulmonary edema if they are under condition of hypervolemia. So probably these are patients that deserve quite proactive approach, good hemodynamic monitoring, and probably, if you are able to deliver that, serial echocardiography. So in conclusion, the diastolic dysfunction is a common issue even in the general population. We have seen it affects outcome both in the perioperative period and in the critically ill patient. The assessment may be not that easy, it requires training, and it can be more difficult in the ICU patient, and we need to do more research about that. But as many times happens, are the simple things that may be rewarding. So keep an optimal filling of this patient. Keep them in sinus rhythm and avoid tachycardia, and ensure a good coronary perfusion, because we have seen that diastolic dysfunction is affected by myocardial ischemia even earlier than systolic dysfunction. And with that slide, I thank you very much for your attention. And that's my email. If anyone wants some slides, some PDF and so on, I'm able to, more than happy to send them. And I'm open to your question. And thanks again for your invitation.
Thank you so much, Filippo. Thank you so much. It was amazing. It was a fantastic. Let's move on to the comments, Filippo. There is an echo. I'm going to, can you please, I don't know if there is a volume, a high volume in your laptop?
I can hear very well. Can you hear me well?
Can you hear me? Okay. Okay, very nice. Okay,
Oh.
there is a question for the audience, Filippo. If you allow me, I'm going to speak in Spanish for a while.
Yeah.
Thank you so much. Ok, parece ser que el doctor Enrique Ochoa quiere hacer algún comentario. Le voy a permitir a Enrique, que por cierto él es residente de cardiología, y vamos a escuchar sus preguntas o comentarios. En este momento ya puedes hablar, Enrique, si gustas.
Okay, can you hear me?
Yes, I can hear you very well.
Okay, yeah. My question is, as a resident of cardiology or as a cardiology in general, it's a very common cause that in the ICU, they ask us to make an echocardiogram in a patient that the intensive care doctor is having trouble in the weaning process. So they ask us to make an echocardiogram. So my question is, when we are asked to do an echocardiograph in that specific setting, what will be the most important parameters that you can recommend us to do in that patients? That's my question.
Excellent question. So if I move on my presentation, I had a couple of slides that may be interesting. I just cast this for, so this is, it seems like, you know, I knew you were going to do this question, but I didn't, of course. The expert consensus on circulatory shock recommend echocardiography as first line. And it's interesting that the expert round table says and states clearly how different, look at here, different from the consultative cardiology echocardiographer. Because today we need intensive care doctor to do echocardiogram by themselves, at least basic echocardiogram, and the expert roundtable says that in the future all critical care doctors should be competent in basic critical care echo, and some of them should be able to do also advanced. Okay, this was a parenthesis, and you know that there is European Diploma of Echocardiography and all those things, and other accreditation process. But if you work in a place where the intensive care doctor wants you to deliver this echocardiogram because of the weaning failure, I suggest, first of all, to evaluate LA filling pressure. So looking at E prime will be one good thing. Then what I can show you as well, that weaning-induced pulmonary edema is associated with preload independency. So usually it may be rewarding to put this patient in preload dependency. It means that they should be offloaded with diuretics and treated with ACE inhibitors possibly. And indeed, the paper from Jean-Louis Teboul, I don't have this data, I should, but it is in this paper. They showed that people failing the spontaneous breathing trial and then treated with furosemide, and some of them also with ACE inhibitors, most of them did not fail the second weaning trial. Because if you fail for pulmonary edema, that means you should optimize the cardiac condition and the circulatory condition, I would say. And if you do that by decreasing the amount of blood that comes back to the LV, then you may be adopting a good strategy. Because we said that when we move from a positive pressure ventilation, even with low pressures, and we move to a spontaneous ventilation, we create some favorable loading condition for the LV. So what I would say look for filling and look for diastolic function, especially with LA pressure as estimated by EE prime. If you can do TDI, because you need machine able to do TDI, and this may be not always available, but that's what I would recommend. Then also looking about the right ventricle, but most of the patient will fail for diastolic dysfunction, I think.
Okay. Thank you so much, Filippo. No sé, Enrique, si tuvieras algún otro comentario, alguna otra pregunta.
No. My question was answered. Yes, because sometimes as a cardiologist, we feel that in that specific scenario, if we do an echocardiogram just like any other, we are not answering the questions for the intensive care doctor. But yes, thank you for the answer. Mm-hmm.
My pleasure.
Gracias. Muy bien, muchas gracias. Filippo, in some papers we have seen that patients with CO monitoring, they had a lower, when the patient is under spontaneous breathing trial, it seems that it is important the CO monitoring, I mean the cardiac output monitoring, because apparently patients with CO monitoring, they have a lower SVT failure. Can you please say something about this?
I mean, you are not referring to this paper by the difference in here. You are referring just generally to the cardiac output monitoring. I think, honestly, if you have a cardiac output, you have are able to differentiate initially which are the patients that do look in a good hemodynamic state to go over with a spontaneous breathing trial. Let's say they've got a good cardiac output. If you got a Swan-Ganz with a SVO2, or if you got all the other values that are normal, stroke volume variation, etc. And secondly, of course, with cardiac output monitoring, you can evaluate if they are preload dependent or not preload dependent. That's another good point. And this is the first part, when you judge if the patient can try the extubation process. And the second advantage is that rather than going blindly to extubate, you may see during the spontaneous breathing trial if the cardiac output is dropping, if the stroke volume is dropping, if you have other issue, if let's say SVO2 is dropping and so on. So I think there are clearly advantages of having a cardiac output in place. And to make it even more practical, I would say if you are going to extubate a patient, and you, or at least you think to extubate a patient in the following 24 hours, and you are considering removal of cardiac output monitoring because maybe you don't need, because the patient seems doing well, I would say keep it until the spontaneous breathing trial, unless you got concern on the line or whatever, because it can be very helpful. I agree it's helpful to have a cardiac output monitoring when you do spontaneous breathing trial, especially if the heart function is not great.
Very good. Thank you so much, Filippo. Thank you. Filippo, another question is, what about the extravascular lung water? Because you mentioned one slide about the explanation why the patients with diastolic dysfunction have a higher mortality. And in my opinion, it's quite interesting because a patient with hemodynamic congestion, why he has a higher chance to die instead of pulmonary congestion. In your opinion, can you explain a little bit more about this explanation of why the patients with diastolic dysfunction die?
I mean, yes, as I said, I'm not sure if diastolic dysfunction is still the cause of the higher mortality, because patients with diastolic dysfunction may be the patient that have got many other comorbidities. So we don't know if it is diastolic dysfunction that triggers mortality, or diastolic dysfunction is just the mirror of patient with a series of other disease, and among them diastolic dysfunction. Moreover, there is an impact, of course, of inseptic cardiomyopathy, the heart function worsen, and of course, you may have a more severe sepsis condition, and therefore the heart can be more affected. So we don't know basically if diastolic dysfunction is just a mirror of severity of the disease. With regards of the extravascular lung water, I think it's all related with the importance of fluid resuscitation at the beginning during relative hypovolemia condition, and then the vascular permeability, because it depends, which depends of course on the severity of the disease. And finally, if this, on top of that, we have a diastolic dysfunction, there is more likelihood that a pool of blood will stay in the lungs and will finally go in the interstitium in presence of high left atrial pressure. So I think it's all about a combination of several factors. And also, we shouldn't forget about the importance of the ventilatory setting, the fact that high intrathoracic pressure may worsen the RV function, causing strain in the right ventricle, failure of the right ventricle, dilatation with shift of the paradoxical septal motion, a shift of the interventricular septum, worse LV filling, etc., etc. And those are very sick patients in that case. I hope I did answer your question.
Thank you so much, of course, Filippo. Thank you. Another question, Filippo. Could you mention the main factors independently associated with WIPO, with weaning-induced pulmonary edema, during the spontaneous breathing trial? Because I think there are a lot of intensivists right now watching your conference, and I think that they are very interested about this specific topic, diastolic dysfunction during weaning process. So could you mention these important or fundamental factors, please?
Thank you. I think most of the studies available, there is one meta-analysis by Almeida, but most of the studies are this one. And my point is that while the LV systolic function is not consistently in all the paper reported as an independent factor for weaning failure, diastolic dysfunction it is. So let's look at the first paper here. Higher E prime. The second paper, again, higher E prime, and was the only independent factor. Then again, the diagnosis of LV diastolic dysfunction. And finally, in the last paper, the E prime ratio. So this is always, it's consistent, but LV ejection fraction, it was associated with failure. But I think in this paper, the group of Antoine Villard-Baron included a lot of sick patients, because if you look at 36% ejection fraction, I'm not surprised that this means higher weaning failure, because these are very sick patients, because 35%, 36 is moderate to severe impairment. But these are not most of our patients, unless we work in a cardiac intensive care. While the other one, here we have that the only factor independently associated is a diastolic index, let's say, but nothing about systole. And in the last paper by Muschiette, again, systole is not associated. So what I recommend when you assess the patient with echocardiography for weaning process, look at the mitral valve, make sure the patient has got no severe mitral regurgitation that for some reason has been missed. Look for diastolic function, and look if there is a severe LV systolic dysfunction. But if systolic function is, let's say, 45% and so on, I would not focus much on that. And then finally, make sure, if you can, from an hemodynamic perspective, if you can work in condition of preload dependency rather than preload independency, then you are more likely to succeed. So let's try a bolus of furosemide. Let's try to offload the patient for 24 hours, because we, by waiting one more day and putting the patient under better hemodynamic condition, we can avoid a reintubation process, which sometimes ends up in tracheostomy, long weaning failure, ventilator-associated infections, and so on, and pneumonia, etc., etc., etc. So it is a very important decision when to wean the patient, and I think echocardiography is probably the best tool that can help us in that. On top of that, but I have to admit I'm not an expert in that field, looking at also lung ultrasound for lung edema, diaphragmatic function and so on. There is a paper recently published in anesthesiology can be of interest. But this paper found that mainly lung ultrasound and transthoracic echocardiogram were important, while the diaphragmatic function was less important in predicting weaning. So this would be my summary in approaching to weaning.
Thank you, Filippo. Yes, indeed. Well, talking about your papers, Filippo, about the prognosis of diastolic dysfunction in sepsis and the meta-analysis and so on, is it the same, Filippo? Is it the same, a low grade of diastolic dysfunction than a higher grade of diastolic dysfunction? Is it the same for all patients, lower than higher diastolic dysfunction?
So it's a very good question. It's a question that we cannot answer, unfortunately, because in this paper, most of the studies allowed to classify patients with diastolic dysfunction versus no diastolic dysfunction. So this patient could have been with grade 1, grade 2, grade 3. This patient had normal diastolic function. So we do not know. Of course, it's intuitive that higher degree may be associated with higher mortality, but we still do not have data to support that clearly. So unfortunately, this question cannot be answered, and this is the problem of currently reported studies. Most of them report data not in a systematic approach. So the number of data you can pull from a very interesting paper sometimes is not that much. There are lots of very good studies, but that could have improved their reporting. And with the European Society, we are working on a project to guide the echocardiography research in terms of reporting. We are working on this project right now.
Thank you, Filippo. Thank you. Well, tenemos en los participantes también al doctor Arnulfo, que es nuestro presidente de la Asociación Mexicana de Ultrasonografía Crítica y Urgencias. No sé si me escuchas, Arnulfo, quisieras comentar algo acerca del tema. No sé si estás por ahí, Arnulfo. No sé si me escucha. ¿Me escuchas, Arnulfo? Okay.
It seems it's not active, the microphone.
Yes, probably. Well, maybe. Okay, perfect. Filippo, we really appreciate your attention. I think that webinar is over. We really appreciate your willingness. Thank you so much for accepting this invitation. This is very fantastic. Maybe on future we will see more studies about this, and for sure you will involve in those papers. We are waiting for more studies right now. Thank you so much. And apparently, well, Arnulfo, okay, Arnulfo no puede en este momento participar. Bueno, si hubiera algún otro comentario, Quique, si todavía sigues ahí, ¿quieres decir algo al final? Quique Ochoa, puedes hablar en este momento.
No, thank you. My questions were answered and my doubts. Thank you.
Okay, very good. Okay, Filippo, we really appreciate. And well, I'm going to speak in Spanish for a while, if you allow me. Muchas gracias a todos por su participación en este webinario. Les agradecemos mucho a todos aquellos que estuvieron también en Facebook. Y pues bueno, agradecerle nuevamente al doctor Filippo esta participación con nosotros. Él acaba de tener a su bebé, entonces se está estrenando como papá y estamos muy agradecidos porque él ha hecho un espacio para estar con nosotros. Verdaderamente, we really appreciate your participation. Filippo, do you want to say something to the Mexican audience?
It was a big pleasure. I think actually I may try to do something similar. I've got, as you know, one 22 days old boy, so I have to focus my energy on him at the moment. But these webinars can be a very nice way to exchange knowledge and to collaborate. So I think we could design something together. So I really think it's a fantastic initiative. Keeps doing it. If you need some further webinar, I'm more than happy to. And if you need some contact with other Italian friends, I may certainly recommend you for this webinar.
Thank you so much. Thank you so much, Filippo. We are really, really honored. And well, see you later. And maybe on future we will see the privilege to see you again in this webinar. I'm gonna finish the webinar, Filippo. Thank you so much once again, and congratulations for your newborn.
Thank you.
Thank you. I'm gonna finish the webinar. Thank you. See you later, and we'll be in contact later. Thank you so much, Filippo.
Thank you. Bye-bye.
Bye-bye. Bye-bye.